I've been a big fan of fat grafting for many years, actually, prior to even the introduction of the first hyaluronic acid filler to our country. I was using a lot of fat grafting, and then I moved away a little bit from it as we got more and more very nice out-of-the-box fillers, and now I'm moving back to it. Why? Because it absolutely is transformative for tissue quality. This is attributed to the stem cells that are present in the fat. So how can we be harnessing that for therapeutic uses? Well, what I talked about in my lecture is we now have systems for fat harvesting that offer us a more predictable longevity. We can get greater viability with these new systems. I have always avoided centrifuging my fat because I felt that it significantly could decrease viability of the living fat cells. And also by compacting the fat, I felt that there was an increased risk of nodules and nodule complications. So now we have these systems that will very efficiently separate out the fat without the need for centrifugation and preserve the viability of the fat cells, which translates into durability of results without having this issue of the increased risk potentially of nodules due to a lump of fat being injected. We now have means of making the procedure safer than ever before. We can use cannulas. I like to use quite wide cannula, typically a 16 or an 18 gauge cannula. 16 is my go-to. It can be very comfortable for patients now that we're using a less traumatic technique, smaller volumes and a smaller particle size for the fat. And those benefits also result in greater safety because we're not traumatizing the tissues, getting the same risk of inadvertent entry into a vessel as with the older techniques. It's really an excellent question to think about patient selection for any procedure. And for fat grafting, I'm going to start by saying that there are some patients whom I specifically avoid performing this procedure in. And those are typically patients who have a very high metabolic rate. I'm in Washington, D.C. I have a cohort of patients who work out for many hours a day. They have a very low BMI. And in my experience, those patients, firstly, it's difficult to find an area from which to harvest the fat. And secondly, they don't tend to retain the fat. The durability is not so great. It's almost as if they burn it off, just as they burn their naturally positioned fat. Patients I find who do the best with fat grafting are those who have a stable BMI, which is not too low, and who have significant bone resorption, particularly in the lower face. It sounds paradoxical, but in my experience, fat is the best corrector for patients who have loss of bone and who have loss of the deep soft tissue. One of the examples that I give in my lecture at the AAD is en coup de sabre, which can result in some quite disfiguring and distressing soft tissue, deep soft tissue defects for patients. And fat grafting can provide a solution that is longer lasting and can be more cost effective than using the typical box fillers. And I found in my experience that patients who have en coup de sabre, patients who have facial hyperplasia or one-sided hypertrophic changes can benefit greatly from fat grafting.